Good morning, everybody. My name is David Tang-Wai. I'm a neurologist at Toronto Western Hospital, and I co-direct the UHN Memory Clinic. And Stephanie, thank you for your story. Yeah, try not to get hit by the thing. And I think that's why we're here. Why I've spent 30 years now of my career trying to do something about dementia. And what can you guys do about it? This is common for me to hear. I do this day in, day out. And I hear people come to me and say, well, I am becoming more forgetful over time. And it doesn't matter what age, doesn't matter what gender, doesn't matter what cultural background. And these individuals who come to me, they have concerns and worries. Am I beginning to have Alzheimer's disease? Is this normal aging? But there's no one in my family who has it. How can I get it? Will I be a burden? Will I be dependent? And I'm fearful. What can I do about it? Got it. Thank you. These are my disclosures. I have no financial disclosures. I've got pop-ups all over the place. I am a member of the Hydrocephalus Canada, part of the Medical Advisory Board. So what is dementia? When I teach this to my students, I simplify it to a simple mathematical addition equation. Dementia is defined as some change or decline in thinking and or behavior. It's also associated with a change or decline in someone's ability to do their day-to-day activities. When it's shopping, cooking, cleaning, planning, doesn't matter. And if those two conditions are present, we call this individual, unfortunately, they have a dementia. And the change in thinking and behavior could be anything. It could be memory, it could be language, or trying to find the right word, or forgetting what words mean. It could be finding a way around familiar places. It could be planning and multitasking. It could be, how do I put these things together when I used to be able to do it before? It could be, I'm becoming more, I don't care attitude, or the reverse, the opposite, is disinhibited, being not able to have a filter. But dementia is more complex. Behavior is more complex. Cognition is more complex. And we now have a spectrum from normal to dementia. And we divide each stage, for the lack of a better term, into subjective cognitive impairment, where someone is knowing that there's something wrong, there's something is different about me, but when I see my doctors, everything is fine. But maybe these individuals are the earliest stages of something going on, of a neurodegenerative process. Then we have individuals who have something called mild cognitive impairment, where there is something going on, and either they themselves know or their partner is aware. There is something that we could see on testing and maybe imaging, but their day-to-day activities are still normal. They're still able to do their day-to-day, and we call it MCI. And at the farthest extreme is dementia, where there is a problem with memory, thinking, or behavior. People are aware of it, they see it, they witness it. There is a change or a decline on testing, and their day-to-day is impaired. And when they satisfy that condition, we call it dementia. And people ask me, well, why is it important to know this? Well, it's about risk. We know that people with mild cognitive impairment have an increased risk of converting to dementia, and that risk is roughly about 7 to 15% per year. That means if you took 100 people with mild cognitive impairment, in 1 year, 7 to 10 of them will have developed dementia or progressed to dementia. Unfortunately, we don't know who. We can identify in that 100 people who could do it or who will do it. But after 10 years, pretty much everyone will change. And now we need to know who are in these categories, because our treatments are going to reflect these categories. So let's address some of the myths and realities about dementia and Alzheimer's disease. So a common thing is, as my dementia gets worse, it leads to Alzheimer's disease. In the end, that's false. Alzheimer's disease is a cause of dementia. It is a cause of those changes, which we'll see in the next slide. All dementias are the same. No, they're not. Each one of those dementias, each cause, whether it's Alzheimer's disease or frontotemporal or something else, have a different course, have a different line of treatment. You may want to try some medications for some and are forbidden in others. So knowing the exact cause is very beneficial. Also, as we develop new therapies to really conquer this disease, to slow it down, we need to be very targeted about what we're dealing with. The last thing is, dementia is a part of normal aging. It is not a normal part of aging. How many people have said that? You know, how many people have heard about that? It's more common as we get older, but I have 50-year-olds, unfortunately, who have Alzheimer's disease. I have 40-year-olds who have Alzheimer's disease. It's not a normal part of aging. There are various types of dementias. Dementia is just that term, what we call an umbrella term, to describe a change in memory thinking with a change in ability to do day-to-day things. But up there, we see various causes. We have Alzheimer's, vascular disease, dementia with Lewy bodies, which is tightly associated with Parkinsonism, frontotemporal, which has often a change in language and behavior. And we have mixed diseases, where you can have two things happening in the same individual, like Alzheimer's and vascular disease is very common. And what makes them unique is what they present with. What is the story of their dementia? How do they start? What other symptoms comes along? How do they progress? And that's how we figure out what type of dementia we're dealing with. And the most important part is we know, for now, if we know what the cause of it is, we are beginning to have therapies. Oops. And this is one of them. We're hoping, this is an antibody, it's called lecanemab, is the generic form. Leqembi is going to be the trade name. This is one of the first new therapies in over 30 years for the treatment of Alzheimer's disease. Unlike the current therapies like donepezil or Aricept, which only handles the symptoms, this will attack the disease itself. It's designed to remove the amyloid plaque from Alzheimer's disease. So we need to know who actually has it and not be mistaken for something else. That's why it's important for us to know what's going on. Unfortunately, it is not a cure. It's the first step towards a cure. It's the first generation of this new field. And we're expecting Health Canada to actually approve it shortly, sometime this year. And we'll be able to hopefully roll this out. But unfortunately, dementias progress over time. And what I get asked about frequently is, well, how do they progress? What's going on? How does it do that? Well, if I look at all the dementias, with the exception of strokes causing dementia, they all have this very common idea. There is an abnormal protein. We all have this protein. But at some point in our lifetime, it changes. And when it changes, it likes to clump together in a nerve cell. And when it clumps together in a nerve cell, it makes that nerve cell dysfunction, makes it aberrantly fire, may not work at all. And then it leads to its death. And then it moves to the next nerve cell, and the next one, and the next one. And there's a very particular profile for each one of them. They start in one part of the brain, and it spreads to another part, and then to another part, and to another part. That's why people don't stop in a certain stage. They unfortunately progress. This is the gross reason, the basic reason for it. How do we determine dementia? What do we all do, whether it's in one of our academic clinics or in the community? We need the story. Story defines what's going on. We want to know the first to the second to the third to the fourth. We want that time course. It's very important for us. We'll do a thorough examination That's why we spend an hour and a half usually with one of us to 2 hours. We want to know, what is this individual's memory doing or thinking? And often it's not what they get right, in my opinion, that's important. It's what they get wrong. And how is it that they get wrong? Because I can figure out what pathways are not working. What is their neurological exam, their physical exam, and their psychiatric or mental health? Then we do CTs, MRIs. We want to know what the brain actually looks like. We want to be sure there isn't something that could be mimicked, that could be treatable, like a vitamin deficiency or a kidney problem. And now, with this new age, we're starting to get very specific, what we call biomarkers. These are either blood tests, PET scans, spinal fluid, unfortunately, and actually tell us what the actual cause is. And we are fortunate now for some institutions, because the government's trying to let us try this out, is to have what we call amyloid PET. It's a picture of the brain, and we can literally picture in the brain where the Alzheimer's actually is. But unfortunately, it's only specific for Alzheimer's disease, and it will not show the frontal temporal. It will not show the vascular, but it's a first step towards that goal. Here's another myth. MRI can diagnose dementia. Unfortunately, I wish it did. It would make my life so much easier. But it doesn't. You need every piece of information available to you to make that diagnosis. The MRI does not picture the small amyloid plaques, that's microscopic, or the tangles, also microscopic. So what can we all do? How can we slow this down? How can we prevent it? How can we delay it? Well, I've kind of put out to here what it takes. It takes decades. We heard the beautiful story before. It takes decades to develop frank dementia. And now we're noticing there's some genetic factors. There's vascular factors, the things that cause stroke and heart attack. If we can address those, we can reduce our risk for developing dementia. There's environmental factors as well. We know that low education, we know that not even exercising, being isolated, not interacting with people, poor hearing, head injury, poor diet, too much alcohol, all contribute to this. And as I said, it takes years to do this. But the earlier we start to tackle these issues, these risk factors, the less likely we're going to develop it. It's not going to be perfect. It's be less likely. Another myth, dementia is always genetic. Not always. There's some people who do have certain genes which increases their risk of developing dementia or can cause it. But some of those, you're not guaranteed to develop it. ApoE4 is a good example for Alzheimer's. You may have it, it increases your risk, but you're not guaranteed to get it. And with the previous slide, there are other reasons that we may get it. And there's one reason overall that we probably were going to get it. It's called aging, and we can't escape that. For centuries, people have been trying to find the fountain of youth. I'm still looking for it. If you find it, share it with other people, please. But we know this works. We know the prevention works. This is the 2020 version now, and there's a new 2024 version coming out in a few months of what can we do to prevent dementia. It's listed all there. What I tell my patients is I don't care, listen to midlife and late life. I actually don't think it should be separated personally. I mean, why would you want to wait later life to tackle smoking? Like hell, do it early. In fact, don't even start, you know? And the theoretical risk reduction is about 35–40%. That's impressive. And we do see it. The rates of dementia is declining because of healthier lifestyles in the last couple of years. So there are studies to now show that. I mean, most of my talk about what can you do about dementia is already in today's program. Makes my life so much easier. My colleague, Dr. Fisher, is going to talk about mental wellness and how it affects us. My colleagues this afternoon or later this morning will talk about sleep hygiene. Poor sleep increases your risk of Alzheimer's disease. So does sleep apnea. Exercise is important, not only from a physical perspective, but also your mental perspective. And then lifestyle changes. So my work is already cut off. Sorry, you guys have got to stay here all day, but I mind. But this is one we could do. It's called the MIND diet. Used to be the Mediterranean diet, but they added the heart aspect to it. It's called the MIND diet. And it's not what you eat. I mean, the people often think, well, for the Mediterranean diet, but I have my olive oil. I have my leafy greens. Yeah, but if you look at the actual diet, it's a pyramid diet. The bulk of one's diet is leafy greens, legumes, vegetables, grains. That's the base of the pyramid. At the very top of the pyramid is red meat. And that's like once a month, and it's about whatever you can fit in your hand. Slightly below that is chicken or poultry, and then slightly below that is fish. So it's not what you eat, it's also how much. What happens if you have dementia? This is what I tell my patients to do. Most people think that their life is over. No. Live your life. Continue doing what you want to do. Do you have a bucket list? Do it. I mean, I'm going to have safety issues in there as well. Don't stop living. I've had families who will say, okay, now we're going to go out to that trip. Do it. Here are some safety precautions. Do you have plans? Have you made your wills? Have you made your power of attorney? We talk about what do they want to do. My follow-ups are very different. My follow-ups at some point become, hey, how are the kids? How are the grandkids? And get to know the person. But you don't want to stop living. You stop living, you start dying. And that's, for me, very important as a physician, is to maintain their health. And that health is everything. And for the partner that's with them, how do you support them? How do you cope? Through education, picking up a phone, counseling. The recommendations I said earlier also apply to people with dementia. Address the smoking, address the vascular risk factors, address everything else, address mental illness as well. And with that, that's going to be my last point. Continue on living. Thank you.